Okay, I'm Peggy Dorsey. I'm the Director of Nurses for Healthy at Home. I think I know a lot of you, but I might not remember all your names. But here to do the second part of the diabetic presentation. You know, back in, I guess last year, there was a sentinel event and somebody had a problem, a patient did, with their blood sugar got too low, and the patient's family did not recognize that, and they gave him his insulin. And anyway, he ended up dying. So that's what this is all about. We're just going to make sure everybody knows the signs and symptoms, because sometimes we forget. Okay, first of all, is anybody here a diabetic? You are. Okay. Are you type 1? Type 2? Type 2. Okay. Anybody have family members that are diabetics? A lot of people do. Are they type 1s or type 2s?
Type 1 and 2.
You have 1 and 2? The type 1, how old a person is it?
She's 65.
Now, so she got it as a child?
Yeah. I think so.
Okay. So thank goodness very few of you are diabetics now, but you know, in the future you could be. So we want to prevent that. So what is diabetes? Does anybody know what it is?
Dreadful.
It is dreadful. How long have you had it?
2002.
Puts a damper on things, don't it? Well, it's inability to turn our food into energy and maintain our body. See, if we don't have diabetes, we don't have a problem with that. We eat our food and it does what it's supposed to, and we're just in good shape. We don't realize how lucky we are until we come up with a diagnosis. Then we realize it a little bit late. So a non-diabetic, our beta cells or pancreas produce the insulin, and that insulin is used to utilize the glucose for energy in our body. So it takes all that food and it makes it into energy. Even fats and normal food can turn into glucose, actually. A type 1 diabetic, we used to call them juvenile diabetics. You know, there's always juvenile diabetics, and type 2 were called adult onset diabetes. Now that's changed. We have type 1, type 2. Type 1 we usually see in children. Seems like recently it's been more in young children. And they really don't know what causes it. There might be some genetic component there, but they're not really sure if they are or not. But they think there might be an autoimmune disorder. So there's something, our body is fighting our pancreas. You know, there's a lot of autoimmune disorders out there, unfortunately, some worse than the others. And so if our body's fighting itself, what can we do about it? And another thing is, it could be from a virus. We had a lady that went to our church, and her child was healthy, had no problems at all, got the flu one winter, and he ended up with type 1 diabetes, a severe case of it. He died as a young man. So they think it is related to a virus. It's kind of scary. So that's probably the reason we see more of the type 1s diagnosed in the wintertime, because that's where we see a lot of viruses, right? Breastfed babies are less likely to have type 1 diabetes. A good reason to breastfeed if you have babies. And these people do not have any insulin. The pancreas does not make any insulin. If it does, it's very minute amount. So they have to be on insulin forever and ever, amen. So they can't live without it. So here's a picture. That's your small intestine. So when food gets in that small intestine, it sends a signal to the pancreas, the little islets there. We've got food here, we've got some sugar here, we need to do something with it. So the pancreas, the beta cells, are the ones that release the insulin. The alpha cells release the glucagon, which is the opposite of insulin. It keeps our blood sugar up if we're not eating. So what happens in type 1 diabetes, those beta cells are destroyed completely. So they're dead, we're almost all dead. So they're not doing any good at all, and so we have to have that insulin to live. Now, if you have a healthy pancreas, which most of you do, the one on top is the healthy one. It releases your insulin. When it senses the food, it releases the insulin. The insulin signal to the cell to open the door. They have they call them like doors, and they're just locks. And they open up, and the insulin can go, so the sugar can go into the cells. But those doors will not open without insulin. Those little locks will not open. Now, the type 1, which is the second one down, the pancreas is not sending anything out at all. So all that glucose is just staying there in the bloodstream and just not able to get into the cell and do what it's supposed to do. A type 2, which is what you've got, that could be caused by different things. It could be a pooped out pancreas. The pancreas is just wore out and it's just releasing a little bit of insulin. Or it could be a runaway liver. And that's, the liver stores glucose as a glucogen. And when our body needs glucose, like if we're doing a lot of activity or during the night when we're sleeping or whatever, it will release that. But for some reason, it goes crazy and it starts just releasing it all the time when it shouldn't be. But the one we see most of is the resistant type. It's 90% of the people have the resistant type. Your pancreas is working fine, but insulin is not opening that cell door for some reason. You see this in people who gain a lot of weight, especially when their abdomen. So if your belly gets there before you do, there's a good chance that you are going to be a diabetic eventually. I said, my poor husband, his belly's way out here, so he's not one yet, but any day now he's going to be one because he won't listen to me and get rid of that stomach. Type 2 diabetes is seen mainly in adults, but we're starting to even see it in kids recently, which we didn't used to see. I wonder why. Because they're overweight, they're obese, and what do? Are they out there playing cowboy and Indian anymore? They're playing video games or watching TV. They're not doing any exercise at all. So they're not doing like we did as children. So we're seeing more and more of these kids with the type 2. Type 2 is the most common type of diabetes out there, thank goodness. And with type 2, you could actually, if you control your weight and exercise and take care of yourself, you might can actually come off the medicine, which is great. For type 1, you're stuck forever and ever. Type 2 is most prevalent in the southern, which is in the south, where we're at, in the Appalachian areas of the United States. I wonder why. We eat a lot. We eat a lot of good old food, don't we? A lot of southern food, southern cooking. Now, the risk factors for type 2 are, if you've got somebody in your family, a first-degree relative that has it, there's a good chance you can get it. Did your family have any? Yes. Yeah. If you're overweight or have an obese abdomen, age 45 or older, your blood pressure is 140/90 or higher. The good cholesterol is 35 or less, and your triglycerides are 250 or higher. Or people who are not getting any exercise at all, they're inactive. If you've had a baby that weighed more than 9 pounds, even if you didn't know you were a gestational diabetic, there's a good chance you could be a type 2. African American, American Indian, Asians, Hispanics, and Pacific Islanders. Interesting, I thought, was that most people have high blood pressure and a high triglyceride for about 10 years prior to being diagnosed with diabetes. About 10 years before. Symptoms, let me talk about symptoms of type 1 right quick. What are the symptoms that you learned years and years ago about type 1?
Polydipsia, polyuria.
The 3 Ps, polydipsia, polyuria, polyphagia. And so these people it's usually, like I said, usually kids, and they're hungry all the time. And most kids are hungry all the time. So a lot of parents do miss it. So they're eating a lot, and they're drinking a lot. And because they're drinking a lot, they go in the bathroom a lot. So the parents don't really see anything wrong with it. But they eat like little Trojans, and they're losing weight. Whereas with type 2, they're not going to lose weight normally. So the symptoms are going to be about the same. A lot of them are the same. You're still going to have the polyphagia, the polydipsia, the polyuria. You could have blurred vision that you didn't have before. You might have some kind of gum infections, a lot of teeth problems, gum problems, skin problems. A lot of times the skin gets real thick. A lot of itching, rashes, abscesses, yeast infections. I said the dry, itchy skin. Unexpected weight loss doesn't happen that often in type 2. Slow healing cuts or bruises, and they start having a little tingling in their feet and extremities, a little numbness. Hypoglycemia, y'all know the symptoms. Have any of you ever had a hypoglycemic reaction? You don't have to be a diabetic to have it. You know, I used to call it the weak trembles when I was young. So, you know, if you're, you know, it's first thing in the morning, somebody brings some nice, fresh, hot donuts in, eat a bunch of them, and then you get really funny feeling because your blood sugar goes way high. Well, then the insulin attacks that blood sugar and it goes down. So when that happens, you get weak, you get shaky, you get sweaty, you get nauseated, you might get a little celiac, a little dizzy. And that's just us not being a diabetic having these problems. But if you have a diabetic and on medicine, can you imagine the problems they have? We had a girl that used to work at Alliance Medical, which is the DME company that was owned by our agency. And she was a bad diabetic. And she lived in Indian Trail. And I tell you, some days she would go home and never make it home. She'd end up in South Carolina somewhere. And the cops would pull her over thinking she was drunk and her blood sugar was low. You know, and that happened many times. So, you know, it's really dangerous for these people to drive. They need to be checking their blood sugars before they even get in their car and have a snack there. They do act like a drunk when it gets real low. We had a preacher come to the ER one night who had a hypoglycemic reaction. His blood sugar was like 30 or 40. He came in, he's fighting, he's cussing everybody in sight, and he's just been horrible. He's really, you know, a real good preacher who would never talk like that in a million years, but he was trying to claw at us and he was cussing us and calling us all kinds of names, things you wouldn't think he knew. Well, we gave him the dextrose IV, and he perked right up and did not know, you know, he didn't remember anything. So he didn't even, you know, just as sweet as he could be. So if you don't take care of the hypoglycemia, then they can get so they can't swallow anymore. They might start having seizures, become unconscious, and they could die. So I'd rather have somebody hyperglycemic than hypoglycemic. So we will prevent this if at all possible. We need to make sure these people take snacks before physical activity. They should understand that foods high in fat or protein and very low in carbs will not prevent them from having hypoglycemia. Some people think it will, it won't. Foods high in fat or protein in conjunction with the carbs may delay the absorption of carbs and have a problem with the medicine and the carbohydrates. So if you gave somebody that was having a hypoglycemic reaction, you gave them protein and fat, even if you gave them something sweet, it would take a long time for it to be absorbed. So you wouldn't want to do that. You want to give them just something, you want to give them the carbohydrates by itself, not give them the fat and protein at first, because you know, it's going to take too long. And that's not what I used to think. I thought you did that for years. If you have somebody hypoglycemia is considered less than 70. So if their blood sugar is less than 70, we need to treat it. So some kind of 15 grams of carbohydrates. It could be juice, it could be soda, but it can't be diet soda. It could be raisins. It could be hard candy if they're still able to suck on the hard candy. You don't want to give them hard candy if they're unresponsive or getting unresponsive. Glucose gel, cake icing. There's, like I said, a lot of stuff you can give them. You give it to them and you wait 15 minutes. And then check the blood sugar again. If it's still low, you give them another 15 grams. Don't let them keep, sometimes when you have these reactions, you just keep shaking and they think the blood sugar is still low, so they want to keep eating. So if they keep eating, they're just going to make the blood sugar go real high. So they can't have anything else. Give them the 15 grams, you know, wait 15 minutes, check the blood sugar. If it's still low, give another 15 grams. And then follow it up with a meal within the hour. Now, if somebody is unresponsive and they're just, you know, you might want to go ahead, if you got glucagon in the home, it can be given IV, sub-Q, or IM. And you give them that, and it's like brain candy. It kind of just takes care of the problem and gives them a big rush of sugar. And it can cause nausea and vomiting. It can make the blood sugar go way high. It stays in the system about 15 minutes, though. So you need to keep monitoring them. And then you need to, once they're able to talk and eat and they're with the program, go ahead and give them a meal. We'll give them something sweet to drink, too. And that little fella, he was NPO and he was on tube feeding. So you really could squirt something, icing or a glucose gel in the side of his jaw or underneath his tongue. And they could have done that if they didn't have the glucagon. So do not keep eating until the symptoms disappear. Avoid using high-fat foods for treatment. It takes a long time to absorb. Do not keep eating after the initial treatment like we talked about before. Always carry some type of carbohydrate. So they need to have a carbohydrate at the bedside table. They need to have it in their car. They need to have it in their pocketbook, just in case they have a problem, a spell. But I said, somebody like that little girl I was talking about, she needs to check her blood sugar every time before she gets in that car and keep something in that car she can eat. They need to wear a diabetic ID bracelet, especially somebody who's very, very unstable like she was. That way when the police pull her over, they know she's not drunk, that she's got a problem, and they would get help. And if they're not able to swallow, you go ahead and put that. I said you can put the stuff in their cheek. If they're able to swallow, you can give them juice or non-diet drink, glucose, honey, sugar, or syrup. And I said the glucagon could be 1 milligram. And you could actually teach the family members how to do that if you need to. I'd teach them how to do it sub-Q though. But like I said, don't last long. You know, you give them a little boost and then hopefully they'll be able to be awake enough to take something in my mouth. If they're not, give them another one. But you need to monitor the sugar for several hours after that. Okay, so pretty much this is what I just went over. And I was always taught adding protein to the treatment of low blood sugar helped prevent it, but undoubtedly that's not what they're saying nowadays. They're also saying if somebody's on dialysis, they do not have to be on low protein diet anymore, protein restrictions, which I thought was new. Have y'all heard that? I hadn't either, but that's what they taught at that seminar.
So giving them fats and proteins on their regular diet isn't going to help them maintain their blood sugar levels throughout the day to help prevent hypoglycemic.
It's not going to prevent it, no. They can still have it, but you need to go ahead and give them protein, but not when they're hypoglycemic. You don't want to give it to them. Okay.
To prevent it, so their healthy lifestyle to prevent.
Yes.
Giving them proteins and fats.
Yeah, they can have.
Help to stabilize. Are you saying that does or does not help to stabilize their blood sugar levels in a diabetic?
They say if you ate a lot of that and didn't eat any carbohydrates much, it would not. Is what the
No, I'm talking about
things say.
dose of both.
I think you'd be okay.
It prevents your sugar from spiking if you couple it with protein.
Yeah,
So instead of going like this, it will just go like this. It will be absorbed longer.
yeah, yeah.
Is that what you're saying? I mean, it almost sounded like.
Yeah, I just copied what they said, so yeah. I said it was not what I thought either. Yeah. I'm thinking what they're talking about mainly is if you had somebody's blood sugar got real low, if you gave them proteins and fats, that's not going to help it. That's going to make it take them long to absorb.
After a protein to actually turn it into a sugar.
Yeah. Yeah.
So, yeah, you wouldn't do it in a hypoglycemic state.
Yeah.
But to prevent that so that they're getting a slow dose throughout the day, you know, and
Yeah.
combining your
Yeah. Yeah.
carbohydrates with your proteins, seems like it's still a good idea, but I'm
Well, I kind of agree with that. Yeah. I said yeah.
just trying to,
Yeah.
sorry.
Yeah, it kind of confused me a little bit too, actually. Yeah. But they did say that there's no protein restrictions at all with dialysis anymore, which I thought was because you need the protein, to help you heal as a building block. I don't know. Anyway, bedtime snacks. When the person gets ready to go to bed that's a diabetic, they really need to check their blood sugar before they go to bed. And if the blood sugar is less than 120, they need to eat an extra snack. So not just the one snack, they need to eat extra snack. And a lot of people's blood sugars will actually go down at 3 o'clock in the morning. Have y'all had patients that do that?
Yes.
So, 3 o'clock in the morning, did they wake up hypoglycemic or what?
Yeah, what is it called? Actually at 2 a.m. It's post, there's a name for it. When your body resets or something.
Yeah, I don't know.
We used to have to check them in the hospital till 2 o'clock.
Yeah, and we need to look at, see what insulin they're on, first of all, and if maybe we need to let the doctor know. And maybe we might need to be, this person needs to be woken up every morning before 3 and just check their blood sugar then and see what it's doing, maybe give them another snack. You know, the insulin they take at night, the basal insulin that they take at night is going to take care of the fasting blood sugar. So your evening, I'm trying to think of the insulin you take in the afternoon should take care of your bedtime sugar. So I'm not really sure. You know, you have to look and see what the peak times were and what to do about that. You might need to change the type of insulin and what time you're taking it, actually. So hyperglycemia, like we talked about the symptoms earlier, non-healing wounds, thirst, hunger, dry mouth, blurred vision, headache, weight loss in the type 1, and yeast infections. Now, they say do not exercise if blood sugar is greater than 250 and you're spilling ketones. How many patients actually check their ketones anymore? Years ago they did. And I think they're talking about mainly about the type 1s because most type 2s don't really have to worry about ketones. It's the type 1s. So if the type 1 diabetic is spilling ketones, they really don't need to be exercising. And what might cause the hyperglycemia would be decreased insulin sensitivity. If somebody's sick or they're under stress, it doesn't have to be sick, like physically sick. It could be mentally sick. It could be like stress in their life. It could be good stress. It could be changes of job, getting married. Anything like that can cause your blood sugar to go up. And especially with type 1s, if they're sick at all, their blood sugar can go sky high. So they need to always take their insulin whether they're sick or not because it will go higher and higher. Decreased physical activity. If you used to get a lot of activity and now you're not getting your activity, that can make your blood sugar go up. An insulin deficiency, not taking as much as you need to take. I read recently for this 19-year-old boy died because he couldn't afford to buy his insulin. It was costing $1,300 a month. He couldn't afford it. So he was just taking a fraction of the dose every time instead of taking the whole dose he needed to take. And I had read that the cost of insulin has gone up. And from 2003 to 2013, it tripled in price. It's gone up 200%. 200%. And it's just ridiculous how much it costs, especially the short-acting type. I forgot it was like $29 per unit or something. It's awful. Like I said, not taking the doses they need to take, they're missing doses. For some reason, people, especially teenagers, they think the insulin makes them gain weight. So they don't want to take that insulin. So maybe skipping doses. And there's a lot of peer pressure. They go out to eat with their peers. They want to do like their peers do. If their peers are eating junk food, they want to eat junk food. They don't want to take time to take a shot. They don't want their peers to know they're taking shots. So they can have a lot of problems because of that. Poorly timed doses or eating a lot more food than you're taking insulin to cover. Can do it.
Can I ask a question in relation to exercise? Let's say you have a type 2 diabetic, their blood sugar is 250. Is there still that contraindication for exercise
No.
at that point?
They don't usually spill ketones.
Yeah, I'm just thinking that.
Yeah.
I don't think I would ever know if they were spilling
Yeah.
ketones or not.
Yeah.
Smells like juicy fruit.
That's the only way you really know.
What'd you say?
Ketone grass, a fruity grass.
Yeah.
I always have to look out for that.
And that's usually, you usually don't see that in type 2 either. You know, they usually don't spill the ketones. It'd be very rare for them to do that, and that'd be in cases like if you had somebody that had been on insulin for years and been diabetic for a long time, that was maybe an alcoholic.
Gotcha.
You might see it. Okay, if somebody's sick, they need to continue their insulin if they're type 1 especially. They need to drink a lot of fluids, at least 8 ounces every hour, and every third hour add some kind of sodium to that. Check the blood sugar at least every 2 to 4 hours, and the ketones every 4. But there again, it's usually the type 1s that check the ketones. Adjust the insulin dose to correct the hyperglycemia. Do not hold or stop the insulin if you have type 1. Continue the Novolog even if they're vomiting and not eating. The body's under stress is going to make more sugar. And you've seen that. If they're sick, that blood sugar might go sky high. They might have no other symptoms at all. If they have an infection, you might not know they have an infection. They have no symptoms, but suddenly the blood sugar is 400. And that is usually the reason. A lot of your patients on metformin. Metformin seems to be the most popular drug out there right now. And it's supposed to have less effect on your blood sugar as far as hypoglycemia. After somebody's been on metformin for 12 to 18 months, you need to start checking their B12 levels. It can actually make their B12 get too low and make them have neuropathy. So the neuropathy might not be for the diabetes, it might be for the metformin. The metformin does work on the liver. If somebody's having IVP dye injected or some kind of dye injected, make sure that they know to hold that metformin for a couple of days before and a day or so after. Metformin can cause nausea, vomiting, and diarrhea, so you try to start out with small doses and build it up. Take it with food. And if somebody eats a high-fat meal while they're taking metformin, they're going to have explosive diarrhea, so warn them about that. So that was pretty interesting. Okay. The patients are to consume 150 to 200 grams of carbohydrates daily in divided doses when they're sick. Soft foods or liquids are tolerated. They need to call the doctor if they're vomiting, if they've vomited more than once, or they've had diarrhea more than 5 times or for longer than 6 hours, or their blood sugar has been greater than 300 on 2 consecutive measurements, or they're having ketones.
So you're holding the metformin because of risk of dehydration with vomiting and diarrhea? Is that why it's being held?
And that, just any severe illness, they say to hold it. Yeah, because it can cause more of that, yes.
Gotcha.
Yeah. There's a rare side effect too you can get from metformin. It calls lactic acidosis. It's like what is it called? It's like a rat poison, like a metabolic rat poison, and it can kill you. You know, so that's one reason too. They don't want to give it to you for serious illnesses. Have you ever had a patient that had the DKA? You can walk by a room and you can smell them. You know, I mean, you don't have to be even close. It could be where she's at, and I can smell her from there. That's just how strong that fruity odor is. And you see that, I said, mainly this is going to be type 1s. Occasionally type 2s, I'll talk about if they're really, really sick and they've been diabetic for a long time, they're on insulin. Or, like I said, they're alcoholic. A lot of times, kids go to the ER because they're vomiting and they're having abdominal pain. And the parents don't know what to do. They just feel the kid feels so bad. And they bring them to the ER and they do a blood sugar and find out they got a real high blood sugar. The parents didn't know they were diabetic. A big percentage of these kids go to the ER and that's how they find out they're diabetics. It's not something the doctor normally just checks for. So, and I used to have a little girl that used to come to the office I worked at, and she'd come in just horrible pain, you know, and dry, hot skin, and vomiting, and she just felt horrible. But those are the signs of diabetic ketoacidosis. But the main sign is that smell. If you smell that odor, you don't have to go any further. You know that blood sugar is high. It's going to be at least 250 or higher, and they're going to be spilling ketones. So if you check their urine, they got a lot of ketones in. So is everybody seen that? If you ever smell it, you'll always know it. And there again, it's going to have the polyuria, the polydipsia, and then maybe they started wet in the bed and they hadn't been wet in the bed before. Dehydration, they didn't spell that right, but you know, tachycardia, now they're getting real dizzy, abdominal pain, vomiting, the breathing, the real fast, shallow breathing. Then they might get combative, drunk acting, could even go in coma and die. They treat them with IV fluids, give them a lot of fluids, and they give them IV insulin. They don't want to bring the blood sugar down too fast. It could cause cerebral edema. So they have to be careful about how fast they bring that blood sugar down. These people are hospitalized with this. We hope to find the problem and get it treated before they get this bad. Has any of you ever seen this? Anybody? This is even worse than DKA. It's hypoosmolar hyperglycemic non-ketonic syndrome, HHNS. So pretty much you see this mainly in the type 2 diabetics. You see it in older people. They're going to have excessive urination, excessive thirst, and they end up having dehydration. They're just, urine's going out faster than they can take it in. They rarely have ketones. There again, it's non-ketonic. They have warm, dry skin that does not sweat. The blood sugar is very high. It's usually over 800 most of the time. It's 600 to 1,000, but usually it's over 800. So it's a lot higher than it is with a diabetic ketoacidosis. They have a high fever, real sleepy, confused, hallucinations, can be weak on one side, and they do not have that breath though. You don't smell that ketonic breath. And it's usually preceded by some kind of illness or infection. You know, they might have had a heart attack, a stroke, or some other kind of event. I think I've seen that once in my career. And it is really high mortality rate on that one. Not good. Okay, a lot of diabetic complications out there. People just don't know what all diabetes can do to you. And young people especially think, I just can't eat anything sweet anymore. That's not it. It can cause all these problems. The main ones we think about, diabetic neuropathy. These people lose the feeling in their feet and legs. They have a pins and needle sensation and a lot of pain. And we got to teach these people they need to take care of their feet and not go around barefooted. I had a man one time who had been working at a construction site, had on boots, got home that night, tried to take the boot off, it wouldn't come off. There was a big nail that had gone through the boot into his foot. Yeah, so, and he was a diabetic, not good. So, they don't feel it. So it's very important that they look in their shoes and they check their feet. Diabetic retinopathy, that can lead to blindness. Then the diabetic nephropathy, the kidney failure, they end up on dialysis. A lot of our patients are on dialysis. I think, don't y'all have a lot? I know we do, on dialysis. And they said pretty much if a type 1, here it goes, 50% of the type 1 diabetics, if they do not treat it early and take care of it, they will end up on dialysis in 10 to 20 years, actually. One more thing about neuropathy. Did you know that there are certain factors that make you more prone to have neuropathy? And then one of them is height. The taller you are, the more chance there are that you might have neuropathy. I didn't know that. I didn't know that. So all these complications are caused by the deterioration of the nerves and the blood vessels supplying the nerves. So you have the microvascular, which is all that diabetic neuropathy on the diabetic retinopathy and nephropathy. And then you got your macrovascular, which is where you see your strokes, your heart attacks. And 65% of the deaths in diabetic patients are due to coronary or heart events. It's a lot. And a lot of times they don't even know that they have silent symptoms. I've had diabetics come in and not even have any chest pain. They might have elbow pain or whatever. They don't have the classic symptoms. Most common type of complications, leading cause of blindness in adults. There were 24,000 new cases each year in the United States of diabetic retinopathy. Leading cause of end-stage renal disease in adults, 44% new cases every year of the diabetic nephropathy. And it's leading cause of non-traumatic limb amputations, 60% of new cases a year. So most of the amputations are going to be, if they're not from trauma, are going to be because of diabetes. And you just have a 2 to 4 increase in stroke risk if you have diabetes. Of course, we know you have an increase in heart attack risk. And I was reading last night, even more increase in cancer risk. Another thing I read last night too, smoking increases your risk of having diabetes type 2. Yeah, big factor. So no good reason to quit smoking.
I just have a quick question. With patients that have silent cardiac symptoms, will those symptoms show up, or will symptoms show up on a stress test?
I think so.
It would.
I mean, according to who's looking at the stress test, though. I had one patient that they said they didn't show up, and then somebody else read it and it did show up. So I don't know. It's got, yeah. The nephropathy is caused by long-standing uncontrolled diabetes. It can lead to kidney failure and then dialysis. And then what's happening is that protein is leaking out into the bloodstream there, and you're spilling it in your urine. And it's not getting rid of the waste like it should from the blood. And how many patients do you have that actually are blind from diabetes? Do you have many? Because there's like 4 stages, and they say pretty much, if you've had it for several years, you start having the damage. And people with type 2, normally they don't know they've got type 2 for many, many years. And by then, when they actually find out they've got it, they might already have the damage started, because it takes about 5 years, and usually it takes a while to be diagnosed. So 21% of the people with type 2 already have the problem before they even know they had type 2. And like I said, the different grades, if you have grade 1, you're always starting to have a little bit of little blood vessels dilated in there. And I've got my little list here somewhere. It tells me exactly how the different stages. But anyway, each stage gets worse. But you can prevent blindness if you get treatment early. So if you're in one of the early stages, you can take care of the problem and not go blind. If you do not take care of the problem, probably you're going to end up you're being blind eventually. But early treatment is the big thing there. The number of people with diabetic retinopathy and sight-threatening retinopathy is expected to triple by 2050 to greater than 16 million. That's a lot. And so these are some other complications and problems you might see with diabetes. Even increase in certain cancers with diabetes. And I said a lot of skin problems. I didn't realize they had so many gum problems. And slow healing, you knew about low testosterone. So with men, that might be a good way to get them to actually be compliant with their diet, is tell them what could happen if they don't be compliant. That low testosterone. Autoimmune disorders. So if somebody's a diabetic, tell them not to go barefooted, check inside their shoes before placing the shoes in their feet. Because somebody could have dropped a tack in their shoe, or they had a baby playing and got a toy in there, or a dog toy, or whatever, and they might not feel it. They need to check their feet and their toes daily, look between their toes. A lot of times they'll get the sores between their toes, and they don't know they're there, they don't see them. Keep lotion to their feet. Their feet are very dry, they crack. So keep lotion on their feet, but do not put any lotion between their toes. Make sure it's nice and dry between their toes. Because between their toes, it's a nice dark place, and it's a good place to grow bacteria and yeast. We don't want to do that. No bathroom surgery. That means no taking a knife or a pair of scissors and cutting on their toenails or cutting on calluses. And that happens too. They do that. They need to wear clean socks. They need to wear shoes that fit, because they might be wearing size 7 shoes with their foot's now an 8, because it has gotten bigger with age. And they've never changed to a different size of shoe. And if they're diabetic, I think Medicare will pay for 2 pair of shoes a year. They could go and get some fitted for shoes and get some diabetic shoes. Because they got some pretty shoes now, actually. Because if you take your shoe and you bend it, it bends right here. That's where it's going to bend. And that's where the diabetics get the ulcers. And that's where the pressure is going. So if you have the diabetic shoes, you're not going to have that problem. So they can get on those diabetic shoes before they break down. That would be wonderful. Once they get the sores, they will not fit them for the diabetic shoes. Insulins. Pretty much you got your different types of insulin and the peaks. So the rapid acting, you need to make sure that the food is still hot. I got a little saying here somewhere. Give the shot when the meal is still hot on that one. It takes effect 5 to 15 minutes. So you make sure you don't give them the shot and wait 30 minutes to give them their food. They need to have the food there in front of them when they take the shot. So take the shot while the meal is still hot. And it peaks in 30 to 90 minutes, and it lasts, duration is a little bit less than 5 hours. The short-acting takes a little bit longer for the onset, 30 to 60 minutes, and peaks in 2 to 3 hours, and duration is 5 to 8 hours. So if you're having a problem with hypoglycemic, you might want to see when it peaks. And then intermediate, 2 to 4 hours, peak 4 to 10. And long-acting, these are the basal ones, and they don't usually have a peak. Usually give those at bedtime most of the time. Levemir is the one we see most, I think. Y'all, what do y'all see most? And of course the diet. You need to look at your carbohydrates and your fats. Too much fat will raise your blood sugar too. So they really recommend a woman to have 45 grams of carbohydrates per meal, 3 meals a day, and then your 15-gram snacks. And most times snack in the morning, snack in the afternoon, snack at bedtime. Now, if I didn't eat breakfast this morning, and I decided I don't want to eat lunch today, I just want to wait and have a big dinner tonight, how many grams can I have?
Usually 45 to 60 per meal with a 15 snack.
Yeah, so if I skipped a couple of meals, could I have any more at the next meal?
No.
No, you can't save it up. You have to do it at that meal. Yeah, that's right.
But you can substitute if you want a piece of cake, don't eat your carbs.
Yeah, you can. You learn to do that, don't you? What you can do, what you can't do. Is your blood sugar pretty well controlled? Mm-hmm. Great. Right. Right. Yeah, it's just amazing look at these drinks. A 24-ounce Sprite's got 64 grams of carbs in it. And a can of Mountain Dew's got 46 grams. So that's, more than a meal. Your brain requires 130 grams of carbohydrates a day. Our brain is what wants that sugar, that glucose so bad. It needs it. I think that's why when we don't have it, we get so lethargic feeling. And these are just portion sizes, and these are snacks that are healthy that would be good for the diabetes, any of us to eat actually. Fresh fruit, the 100% frozen fruit juice, air popped light microwave popcorn, fresh veggie slices with salsa, lean turkey on a whole grain cracker, celery sticks filled with peanut butter. And then on the left, it tells you what the portion sizes are. Not much, is it? A1Cs. It depends. The American Diabetic Association goal for a healthy person our ages would be less than 7%. The American Association of Certified Endocrinologists, their goal is 6.5%, so it's less. And that's just for us, pretty much. Now, if you have somebody that is a healthy, like you've got an 80-year-old, 85-year-old, less than 7.5 is what their range is. And if they're in the nursing home and they're in poor health, they'll go for less than 8.5%. So, but it can be falsely elevated iron deficiency anemia, falsely low in dialysis patients. I don't know if y'all, let's see, I need to do there. Decongestants and some cold medicines can actually raise your blood sugar. Aspirin in large doses can lower your blood sugar. Some antibiotics can lower your blood sugar. And a lot too depends on when you give your insulin, where do you give it?
I get mine in my belly.
You get your that's right. You know to rotate sites, everything, but they say to keep your blood sugar more steady, I guess, like you want it to be, so you get the right results. If you do it here, and then you do it here, you're gonna have different absorption. Right. You get the best absorption in your stomach, and the next would be in your arms, and then your thighs, and in your butt, actually. So you just don't want to go. Try to stay in the same part of the body, is what they're saying.